Well, welcome everybody to our second virtual MOTA CEU. This is something that we had such success with our telehealth CEU that we decided this is something we try and offer monthly going forward. So we're pretty excited about that. This is an initiative that MOTA's really been working on, is trying to offer more value and CEU opportunities to our members. So assuming that everything continues to go well, we should be able to provide 12 yearly CEU hours. So just by being a MOTA member for 2 years, that should get you pretty close to being able to renew your Missouri license, because I believe the requirement, I think, is 24 hours. So this month's edition is about addressing low vision. And we have a wonderful guest speaker who agreed to do this on such short notice, is Stephanie Stegman. Stephanie graduated from Maryville University in 2008 and worked at Barnes Jewish Hospital for 9 years, including as an occupational therapy lead for 6 of those years. She's a PRN at skilled nursing facilities on the weekends for the past 8 years. And she often teaches, lectures, and does labs at Maryville and Washington University. She's a volunteer for Rebuilding Together St. Louis, completing home safety assessments annually for the last 9 years, and is currently working at Washington University in community practice as an outpatient therapist, providing services in the home and community, as well as services in a primary care clinic. She's currently enrolled at UAB in their low vision certificate program, and she is here today to offer us some great tips and education on how to address low vision. So Stephanie, I will let you take the lead.
All right, well, thank you, Clarice, and thanks for MOTA for having me. It's kind of a win-win for both of us, because as she mentioned, I'm enrolled in the UAB program, and we'll talk a little bit about what that looks like, but I'm going into my 3rd semester of five semesters, and one of our projects was an advocacy project where we needed to do a presentation or do something like that related. So I reached out to MOTA thinking about conference, and they were like, well, actually, you could do a webinar. And how about in 3 weeks? And I said, that works for me. So I got on the schedule. I do have a lot of experience throughout the continuum of care, from acute to home and outpatient and SNF. So I'm hoping to incorporate that and give examples to you guys that are applicable throughout every continuum, but feel free to pipe in or ask specific questions. We've got the chat box on the side. I'll try and monitor that, but then Clarice, also feel free to watch the chat box for me and help flag any questions that pop up. So I'll start out by saying that I am by no means an expert in low vision at this point. I am on the pathway there. It's a long process, and we'll talk about that, but I have had a wonderful mentor in Monica Perlmutter, who works at WashU, and she has every certification you can have in low vision, and so she's been my one-on-one mentor throughout this, and she was gracious enough to work with me on the presentation and share some former presentations that she's done, and then I took a lot from my courses at UAB. I felt like once I got into the deep education of low vision, I came to realize how much was applicable and that we could be doing and incorporating as OTs in any setting with any client, and we'll kind of talk about that. But so anyways, long story short, thanks for having me. See if I can, it says host disabled participant screen sharing. Can you allow me to share screens, Clarice? Move this out of the way. Okay, you guys still hear me okay? Okay, so I have no disclosures. I don't get any money from anywhere else, unfortunately. So everything I talk about today doesn't benefit me in any way. So objectives that we wanted to hit was, kind of talking about what does it look like for a low vision team, understanding kind of the primary diagnosis that impact low vision and occupational performance. There's a ton of things on vision. I mean, obviously I'm spending 5 semesters just on low vision. That doesn't even include visual rehab. So like things with neuro and the therapists that are doing, eye exercises and eye strengthening. We're not even touching on any of that. That's a totally separate field. So for the specifics of today, for just the 1 hour session, we're just doing low vision with older adults specifically related to these top 3 diagnoses. Talk about some interventions and screening tools, and then kind of set you up with some resources, things that are helpful. So you can't really start out anything without talking about some of the facts of vision. 12 million people have visual impairments and only 1 million of those are blind. A lot of adults are at high risk. There's a huge economic impact, vision disabilities in the top 10. And, it causes a huge change in somebody's life for, productivity, disability, quality of life, those sorts of things. So that's all straight from the CDC. If you look at the occupational therapy practice framework, vision is listed as a very important client factor that has a significant impact on occupational performance. And it was interesting. So I attended virtually the conference for the skilled nursing facilities when the PDPM rolled out. And Jeremy Furness, who is the director of quality at AOTA, gave a presentation, and they were talking about a big study that AOTA had just done that they hadn't quite released all the results of yet. But it's essentially saying that they've now identified 8 core areas that should be addressed across all areas of practice. So kind of like a minimal assessment, if you will. And so the things that they listed were ADLs, IADLs, cognition, psychosocial behavioral skills, fear of falling, habits, routines, and roles, a safety screen, and then vision. So AOTA has even identified that in any assessment, vision should now be one of the top 8 components. Not that that means you have to do a full standardized assessment with that, but at least be screening it or touching base on it, or looking at it in some form or fashion. Vision is our most far-reaching sensory system, right? So it helps us anticipate, it helps us plan, it helps us react, it helps us engage in a dynamic environment that's quickly changing. It helps us interpret social interactions and elicit and guide movements, right? You see something, you want to go get it, you move your body for it, right? So vision plays an important role across all aspects of every occupation. So then to talk a little bit about what it means to have low vision. So normal vision is in that range from 2012 to 2020. So their estimates are saying normal reading performance and distance, and then you can kind of see it striated out. So a lot of confusion exists, I feel like, because back in the 1930s, the US government coined the phrase of legally blind. And so there tends to be this confusion around what does it mean to be legally blind versus having low vision versus being totally blind. And so the legally blind falls in at 2200 and anything worse than that. As far as reading these acuity levels, essentially what it's saying is, say if you're 20/30, that means what most people can typically see at 20 feet, or I'm sorry, what most people could see at 30 feet, you would need to stand at least 20 feet. Like you have a shorter distance to be able to see and interpret those. So what it's, so if you had 2500 vision, that means what most people can see at 20 feet, you would have to be at 500. I'm sorry, I keep doing that backwards. What most people would see at 500 feet away, you would have to be 20 feet or less away to see clearly. So that's kind of how those break down. So in order to qualify for being legally blind, somebody has to hit that 2200 range or have a visual field of 20 degrees or less in their dominant eye. Low vision, so what we're talking about here, so the range of normal vision, the near normal vision categories, not a whole lot of modifications, right? They just might have to get closer to things. But when you hit that moderate, severe, profound levels, that's when the low vision rehabilitation is really going to be the most useful and the most key. And then once you hit that near blindness, there might be some things that we're able to do. But then total blindness is essentially that no light perception, no vision. And that's when somebody needs to be in the actual blind system instead of like low vision rehabilitation. So if anybody has any residual vision, they will attempt to use it. So I think that's a really key thing to think about. And when we talk about low vision rehab, one of the things that we really want to advocate for is our services. Because most of the time, physicians, when they're assessing patients, it's negative news. So it's, oh, you've lost this much vision, right? So they're focusing on how much vision you've lost. And every time you go to your appointment and you get tested, that's the big concern, right? But really from OTR perspective is how can we maximize the vision that you have left? So no matter how much is left residually, our goal is to maximize that and make it as effective as possible for you to still be able to participate in the occupations. Because if they have it, they're going to use it or try to use it. So there's basically two big systems of low vision. There's the blindness system, which is state, private, federal sectors, and then there's the healthcare system. So it really wasn't until recently, like in the 90s, that the healthcare system expanded. Prior to that, the blindness system kind of pretty much had a hold on low vision services. So they primarily focused on like return to work, working with children, doing education and training. They had some ophthalmologists and optometrists, sorry, it was a text from Claire, so I was thinking she was telling me something about the webinar. So I had to look at that real quick. But essentially, there wasn't quite this niche for low vision that impacts all these seniors, right? And we'll talk about like how prevalent it is for seniors to end up having these like low vision adaptations. They just weren't getting the services that they needed within the fully blindness system, or they didn't think that they qualified for services through the blindness system. But then, so what it looks at, so there's an ophthalmologist, and I never fully knew before what the difference was between the ophthalmologist and optometrist. I would be like, yeah, whatever eye doctor you see. But the ophthalmologist is actually a medical doctor. So they're an actual physician. They diagnose, they treat, they do surgery, right? It's like a typical physician, but they specialize in eyes, and then they can have subspecialties of that, like neuro and stuff like that. The optometrist is actually not a physician. So they have a doctorate of optometry, but they're not a medical doctor. So that played a huge impact for a lot of years, because that meant that OTs couldn't get referrals from optometrists because they weren't a medical physician. So then there's certified vision rehab therapists. And essentially what they are is they're like a rehab teacher. They're a complement to OT. They sound a lot like OT, where they look at ADLs and self-management and home environment, adaptive equipment, but they're really good at like Braille and assistive technology specific to low vision. But the difference for them and the orientation and mobility specialists, which I'll mention, is that they are not covered, they are not considered healthcare providers. So they can only function within the blindness system, right? Or have like private funding, grant funding, that sort of thing. Just like the certified orientation and mobility specialists. So they have a certification and they have a degree, but it's primarily focusing on, you know, blindness, long canes, teaching people that are blind how to move. But again, they're not considered a health professional because they're not in the health degrees. There's certified low vision therapists, which can be any number of disciplines. So it's accredited by the same body that accredits the O&Ms and the vision rehab therapists. So like nurses could be a certified low vision therapist, like anybody that has a degree and sits for this examination. OTs can be low vision therapists, so that's what I'm working towards, and I'll talk about that. OTs could also get a dual certification in the orientation and mobility specialists. And OTs are the only ones that can get reimbursed for those services in the typical medical model because they can bill it under community reintegration. which is kind of nice. So then there's OTs and OT assistants. So it really wasn't actually until May 2002, so that was not that long ago, 18 years ago, that CMS finally recognized and would allow Medicare to reimburse the healthcare model for specifically low vision services. So this is like a really unique time for OT to step up, because not only are we able to get reimbursed for these services, but we're the only ones out of this whole list, other than the ophthalmologists and the optometrists, that can bill through a medical model for our services. So there's a few specialist pathways to go to for low vision. So there's the graduate certificate program in low vision, and that's what I'm enrolled in now. There's several different universities that host it. I'm at UAB. I just felt like they literally, like Mary Warren and Elizabeth Barstow, like wrote the book on low vision for AOTA. And their program is certified in that if you go through their program, it cuts time off the other certifications. So you can fast track through these other certifications, but I'm sure there's other programs that are wonderful as well. It's about $2,000 a semester, and it's 5 semesters, so it's kind of pricey, but I'm incredibly fortunate that my work, WashU, is supporting me through that. So then there's the AOTA specialty certification in low vision, which is those credentials that you see listed there. So for that, it was that you did a portfolio. They're now changing it. This past December was when they kind of canceled all the portfolio applications, and it's now going to move to a test-based certification, which I don't know when that's going to come out. I think everything has gotten a little delayed at AOTA with COVID and that sort of thing. So we'll see when that comes back out. But that's specifically for OTs through AOTA. And then the certified low vision therapist, which was on the slide prior, that could be multiple disciplines. But you basically have to have a degree, at least a bachelor's, or like OTs can have the graduate certificate. You have to have 350 hours supervised by somebody who is already a CLVT, and then you have to take an examination. So like even going through just getting the graduate certificate, you still have to do so many hours of supervised observation and then still sit for the exam. So that being said, there's not a ton of low vision certified specialists, right? So I kind of looked up the numbers on the websites. It said in Missouri, there's a little less than 3,000 OTs that were licensed. And I looked up who was certified through AOTA for low vision in Missouri, and there were only 2 listed on AOTA's site. So out of 3,000, there only looked like there was 2. And then I could only see 14 listed in Missouri under the CLVTs. So there's, if we're talking about low vision impacting seniors in these huge amount of numbers, and there's only a certain amount of specialists, we really, as OTs, need to be kind of stepping in this opportunity that we're getting reimbursed for low vision services to provide them as generalists, because you actually need no specific credentials to provide low vision rehab. So like you could go and provide a full low vision assessment and intervention and bill for it without having any specialty certification. Obviously, AOTA is encouraging the increased certifications and education, but you don't have to have it. We know that low vision comes with a lot of comorbidities. I don't know of any patient that doesn't have a ton of comorbidities, right? So there's always pretty much any referral that you get, you want to be at least asking or screening for low vision if they are a senior. So the generalist should be doing like visual acuity, contrast, visual fields, eye movement, looking at person environmental fit. Intervention would be considering if vision loss is even correctable, looking at modifying the environment or the task, especially those high risk areas like fall prevention and medication management, which Mary will talk about fall prevention at the next MOTA CEU. And then adjustment issues, so psychosocial. So we'll talk about that, but the huge impact for mental health once you have acquired vision loss, especially later in life. And then provide resources and make referrals. So if there's low vision therapists available, make the referrals, get them involved. But there's definitely a lot that every general OT could be doing. So just kind of briefly talking about the components of low vision. So We've got visual acuity, so that's the detail with what you can see objects with, the visual field, so like the total spread of the vision. Contrast sensitivity, so being able to distinguish things, capacity to regulate light, visual perception and interpretation, so can your brain actually interpret what your eyes are telling you that it's seeing. We'll reference this slide a couple of times throughout, but a few things that I wanted to just point out for the diagnosis purposes. The big blue thing, do I have my, can you guys see my cursor if I move it? Okay, so like here's the lens. So that's gonna be important when we talk about just mentioning cataracts. You've got your optic nerve back here. You've got your retina, okay? And we'll kind of come back to this as we talk about each of the different diagnoses. Age-related vision changes happen regardless of some diagnosis. So just as you age, there's things that happen no matter what. So needing an increased need for lighting. So an 80-year-old needs 10 times as much as light as somebody in their 20s. Now we establish our lighting preferences in our 20s. And then we never change them. So whatever you decided that you liked in your house is what like has stuck in your house. If you're like one of those like soft yellow people or the real bright clear daylights. So that's, you don't even recognize the need that you're needing increased lights. I don't know about you, but a lot of times when I go into my seniors' homes and they're like pitch black and they're like so dark and I'm like, turn on the lights around here. So that increased need for lighting happens because your pupil diameter starts decreasing as you age, and then your lens, so that thing I pointed out, starts thickening and yellowing, right? And so if you have an increased need for light and you don't have it, you're at a higher risk for falls. You're also susceptible to glare, so the lens and the cornea become less smooth, and there's protein strands that make light scatter as it comes through your eye. So that's one of the reasons people might stop driving at night, is because, you know, the glare that happens, you know, when it's dark and then you pass a bright light, and dark light adaptation. So difficulty with transitioning from light to dark rooms, dark to light rooms. So, you know, if you're outside in the sunshine in a parking lot and then you walk into a dark store, people can be at a higher fall risk because their eyes haven't transitioned yet. Reduced contrast sensitivity. So a 75-year-old needs twice as much contrast and a 90-year-old needs 6 times as much contrast. So that can lead to falls, you know, cuts in the environment. So if things aren't really well contrasted, thinking about, you know, like a curb step in the sidewalk, if it's not brightly painted and identifying that it's actually going to dip there, that could be a high fall risk, right? Because they don't have that contrast sensitivity to see that there's actually a dip that's going to happen in that sidewalk coming up. Reduced color perception, that's from the yellowing of the lens. So that leads to, like, you know, some of the mismatched clothing, black pants with blue socks, or that blue-gray hair that you see some seniors wearing, right? They don't quite have that color perception down. And then reduced visual attention. So having an attention field of less than 20 degrees, they don't have the ability to shift between the central field, the visual field that's right in front of them, and the perimeter. And so that's when you see a lot of car accidents happening, because they don't have the attention span to filter between both. So just a quick reference back to this slide to make it easier as we talk about it. So macular degeneration is the deterioration of the photoreceptor cells in the macula at the central portion of the retina. So if I go back to that here, that's right where all those photoreceptor cells are going to start breaking down. So there's a dry kind, which is the most common kind. It's what happens in 90% of them. But basically what happens is, like, fatty proteins deposit onto the retina, and that's what you're seeing demonstrated kind of in the pictures here. It's what results is what we call scotomas. So those are within the central vision, which is where directly whatever you're looking at, and you get those kind of blackout spots. They can be really light where you can see through them, or they can be really dense. There's all kinds of different sizes, and you can have many of them. And what's interesting that we'll kind of talk about is that your brain compensates and fills in the gaps. So most people that have macular degeneration don't even know that they have scotomas because their brain's just filling in the gaps and they don't even know what they're not seeing. The wet kind is a little different, but that only happens with 10%. It's a little bit more urgent and critical when that happens because it's actually a neovascularization, which means that there's blood and leaking of the fluid into the eye. And macular degeneration is the leading cause of vision loss. There's no cure for it. There are some things to manage it. It does cause permanent vision loss, but it does not usually lead to blindness. So it's usually affects like, leaves you with up to 20% of your vision loss, but not total blindness from the scotomas. So like I mentioned, nearly 2/3 of all people that have those central scotomas, so those blackout spots, don't even realize that they have them whatsoever. So this is going to be important when we get to talking about screenings, because if you're saying, have you noticed any changes in your vision? They're going to say, nope. So it's going to be important to dig a little deeper. Preferred retinal locus PRL training. This is a higher level skill. There's a really specific way to go about doing this. We could spend a whole hour just talking about how to do PRL training. But what essentially it is people have a certain spot in their eye that they focus on always. That's called your fovea. And it always goes, and if you have a scotoma that's right in the middle, so in that black spot there, you're going to be always looking right through that scotoma. So it's training people to change the location of this fovea inside their eye to kind of redirect their vision. So it might mean looking above whatever you're trying to look at in order to see it clearly, or looking to the left of whatever. It's like moving those scotomas out of the way in a very specific way. A really important role for OT in macular degeneration is self-management. So the risk factors for the macular degeneration, you know, make sure they stop smoking, reduce, eliminate saturated, that's supposed to be fats, not bats. Engage in aerobic exercise, wear sunglasses with UV protection, avoid excessive alcohol take and nutrition. So those are all self-management things that we can address. Back to the reference anatomy slide, there's diabetic retinopathy is the other big one. So essentially what happens with this is that high levels of blood glucose destroy the integrity of the walls, and you basically have leaking and bleeding into the retina, which causes edema, and then new fibers grow and they pull away the retina, and it actually causes total retinal detachment if it's not gotten under control. So this is the most preventable eye disease if you manage it and manage your diabetes well, but yet there's no cure for it once it starts happening. So you can prevent it from getting worse, but once you've got it, and it will lead to total blindness. The big key for this with OT is this diabetes self-management, right? So being all the things that we would normally do with somebody with diabetes. So if you see a patient, even if they don't have diabetic retinopathy, that's not listed anywhere, but they have diabetes, I'm talking to them about their vision, right? And the importance of these things to say, have you gotten your vision checked recently? Are you monitoring these things? This is something it could lead to because it happens with type 1, type 2, or even gestational diabetes. Back to the reference picture for the anatomy. We talk about glaucoma. So if you're basically, you see the optic nerve at the to the right side of this here. I can't find my cursor, but glaucoma is basically a collection of diseases that affect that optic nerve. So normally there's a normal amount of fluid that's within this vitreous body here, right? And there's an equalized pressure. So there's always a certain amount of pressure in your eye that's kind of normalized. What happens is there's a trigger, that pressure increases, it has nowhere to go for that fluid. So it starts putting pressure on the optic nerve is the only way to get out. And that pressure ends up reducing the blood supply to the optic nerve, and that ends up, can lead to total blindness. So glaucoma is scary in that you have no idea it's happening and you have no idea it's coming on. It's kind of this tunnel vision, as you can see in the picture, and your brain compensates. So they call it the silent thief of sight, right? Because all of a sudden it's, you can be totally blind without even realizing that it's happening. So early medical detection, regular eye exams is critical. Regular exercise can lower the intraocular pressure, but you want to avoid inverted positions, like if you're a big yoga person. Wear eye protection, watch your diet. So caffeine can increase that pressure, or drinking a ton of fluid at once can increase that pressure. And then with glaucoma, the management of it is a really strict medication routine, which is really important for us as OTs. Because they have this really complicated, all these things with eye drops, right? So it's like a couple different versions of eye drops, and they have to do a couple drops each. But what I found was interesting is that there's actually a very specific way that you're supposed to be taking eye drops, and I don't think I ever realized this, but this is a good teaching point and strategy for OTs and medication management. So this is a copy of the instructions from the NIH as far as how to do these specific low vision eye drops. But the things to note is that after a single drop, you're supposed to wait 1 full minute before putting in the next drop or the dosage, because otherwise if you do 2 drops, if that's your prescription, and you do them both at the same time, they just wash each other out and they drain into the tear duct. So in order to get the full dosage, you have to wait 1 minute in between drops. And then if you're doing multiple drops, you have to wait at least 5 minutes between the different types of medications. So that's like a really extensive medication routine. And I don't know about you, but like when I'm in somebody's house and they're doing it, or I'm at the nursing home, right? Like the nurse walks into the room and they're like, here's your eye drops, right? And they just do them all within like 30 seconds. So I think that's an important thing to do or realize with these low vision medication management. And I thought it was just worth mentioning for cataracts. So back to the lens, that big bluish bubble there on the inside of the eye. So I always hear people saying they have cataracts, and it's essentially when that lens becomes very cloudy. So it can be easily fixed. I say easily, it's like an outpatient surgery. They just slice it open, pop the lens out, pop a brand new one in, and it's clear, right? You can see totally through it. It's not yellowed or opaque anymore. But what's interesting is that Medicare will not cover that surgery until somebody's vision hits 20/50 or worse. So just know that before they get that surgery, even though once they get it, it will be fine, there could be some impairment that happens in between that time that they could benefit from some modifications for, because that's a big adjustment to go all the way down to 20/50 or worse. Okay, so we'll talk a little bit about assessment. So questions that I have now tried to integrate into my practice to ask are things like, when was your last eye exam? Have you noticed any changes in your vision? Do you have a more difficult time or take longer to do some tasks than before? And are there any tasks that you stop doing because it's hard to see? So really trying to like dig a little deeper in. Because like I said, if they're not even realizing they have scotomas with the macular degeneration, or they don't realize tunnel vision, you know, those are ways to just kind of trigger them to think a little bit harder. And then when you think about reading, additional screening questions, like if you were going to focus on some of that, it's, can you complete any, like, do you do any reading now? Is it just like medication bottles and, you know, microwave meals that you're reading, or are you still reading for pleasure? How long has it been? You know, and then what are your complaints in reading? So that's going to tell you, if they say, oh, the print's too small, that's going to trigger you to think it's something with their acuity. If it's not dark enough, that's going to tell you it's something with the contrast. Or if parts of letters or words are missing, that should trigger you to think it could be a scotoma. So general testing principles, anytime you go to test vision, would be making sure that you have optimal lighting in the room that you're testing them on. So whether that's like a task lamp or overhead lighting, clean glasses, because for a lot of these tests, they'll be wearing their glasses. And I don't know, I mean, any patient I have, their glasses are never clean. I started carrying around like those little disposable wipes that I just keep in my bag, and I clean people's glasses before we do testing now. Make sure they're in a comfortable position. it's a quiet area, and that you do the required distance for the testing. So if it's saying, you know, 16 inches or whatever it is, you want to make sure that you're not modifying that distance. And then they need to be able to provide reliable answers, which can be a little hard. You have to circle around sometime. So eye dominance for fixation. Can you guys see me well enough if in the little picture, or do I need to stop sharing the PowerPoint? If I demonstrate something, can you go, okay. So eye dominance for fixation is important. So just like we have a handed dominance, people also have an eye dominance. And the reason that this is important is because whatever eye is dominant is going to be the eye they would go to use with a magnifier. So the doctor might have prescribed them a magnifier based on their acuity level for their non-dominant eye, but then they go to use the magnifier and they're using their dominant eye, right? Or maybe the dominant eye actually has a much worse acuity, and so you actually want them to be using the non-dominant eye. So it just depends. But how to test eye dominance is you don't tell them what you're doing. So you don't say, I'm going to test your eye dominance. And you hand them a piece of paper that's just got like a little punch hole in the middle of it, like a little card. And then you're holding another card that has whatever drawing on it that you want. And so basically you hand them this little hole and you say, okay, I want you to look through this to find the flower. And they're automatically going to put that up to their dominant eye. So you've now found their dominant eye. If you don't have cards, you can just roll up a piece of paper and do a tubing and do that as well. So it's really simple and easy to kind of check for, even if you're in a place where you don't have a ton of resources. But make sure you're not telling them why you're doing that. Visual fixation, that's essentially just making sure that they can focus on a single target. So, you know, whether you're holding that in front of the card in front of them and saying, I want you to just fixate on that, don't move your eyes. So you're looking at the visual attention, and then you can kind of move that in different places. That's going to be important for when you do some of your other testing. So direction of gaze. So that's when you are going to tell them, all right, look left, look up left, look down left, right. So you're having them go through all those different motions. So you're making sure that they can move their eyes in all of those directions and that they can track things. And then near visual acuity. So you're going to always test the dominant eye first, and then the other eye, and then both eyes together. For occluding, you know, you can hand them an eye patch or, you know, cover their eye with whatever you need to. They can hold their hand as long as they're not squishing their eye. This is like the Lighthouse near acuity testing card. And it has a nice little string on it. So that tells you the exact distance that you need to hold it away. So that's your testing distance. So you would just hold that up to your eye for the test. You're gonna have them start at the top, like at the very top, even the biggest numbers. That's gonna build confidence. So have them start at the top, even if they can see all the way to the bottom, right? You're gonna have them start there and work their way down. So basically wherever they stop based on whichever line it is, that tells you, I can see what the acuity is. So, you know, if they get at least half right in that certain line, then that tells you their Snellen level. So like that 2200. So then underneath that on the slide, you see how to write out your acuity shorthand. So OD is right eye. So you might see like OD 2200, you know, OS 2040, OU this, and then with correction or without correction. So when you're testing it, have them wear their glasses, okay? Because you're testing their near reading ability with their glasses. So you want their glasses on as you're testing the near visual acuity. So the Snellen notation, like we talked about, is the 2020, 2030. I'm gonna see if I can pull this up on, can you guys, is this showing backwards for you guys? No, okay. So on one side of the chart, there's, you know, the 2200, but then on the other side of the chart, you can see these M's where it's like 4.0 M, 2.0 M, right? So That's actually a metric metric measurement of acuity. And what's interesting about this is that it's actually going to tell you what exact size print would work best for them based on their acuity. So that's going to give you a direct correlation to like what size print their handouts need to be or things like that. So essentially, we're kind of going to flow through this, but like a 1M equals a 10-point font. And you can actually convert the M's back into Snellens by just timesing them by 20. But we'll kind of move through. I don't want to get caught up here. An hour goes by so fast, you guys. Okay, contrast sensitivity. So that's a standardized assessment that you're seeing on the right side, the Pelley-Robson. It's super expensive. I mean, just something like that is a couple $100. So I don't think it's worth it just to like purchase for general practice. But you can look at contrast sensitivity really easily by having them try and find ADL objects in the room, or like, you know, putting white toothpaste on a white toothbrush, or, you know, like you can test it all kinds of different ways, or just by asking them, like, do you have difficulty like picking things out? Confrontation visual field test. So that's where you're right in front of somebody, you have them focus on your nose, and then you're bringing the stimulus around in the quadrants, and they're telling you when they can see them or not. You want to be able to occlude one eye at a time when you're doing that. And then I'm just going to keep going. So the color perception, I thought it was interesting. You guys have heard of those in chroma glasses now, you know, where you like see all those videos of the people crying now that they can like, they're colorblind and they can now see when they wear these glasses. You see those like viral videos. Well, their website actually has a free colorblind test now. So I put the link of it on here. So what it looks like is, you know, they're like colored dots, and then there's different colored dots, and you have to say what number you see in there, if you can see it or not. So it goes through like a whole bunch of different slides, and then it tells you whether you're impaired or not. But I still call it an informal one because it's not technically like a standardized assessment. It's just off a website, but that's something easy to use. Otherwise, you can just test them based on their own clothes, right? Like, here's your pair of blue and black pants. Can you tell the difference between them? Central scotoma awareness. So like we talked about how they're not even aware that they have scotomas. You can use the face fields method or the paper target. Essentially, either one is the same. So what I would do is I would have the person look directly at my face, like look directly at my nose. And this is where the visual fixation is important. So you want them not to modify their eyes. You want them to stay looking directly at your nose. And when they're doing that, is any part of my face disappearing? Is there any part of it that you can't see or becomes blurry? Or the same thing like when they're looking at the clock. So look in the dead center of the clock. Are there any numbers that are missing when you're looking in the center? And that's how you help them develop that scotoma awareness, is making them become aware that certain parts are blurry when they're looking in the center of the vision, or when they start then moving their eyes around, how different numbers come in and out and start disappearing. We going okay so far? No major questions? Okay. So then we want to really look at the environment. So when we talk about a static versus dynamic environment, static's where everything stays the same. Dynamic, I would say everything is moving. So like when you go out into the store, people are moving around you, cars are moving outside, that sort of thing. Novel versus familiar. So home is very familiar, and this is kind of one of the things that we would advocate for somebody aging in place, right? So if they have low vision and it's an environment that they're familiar with, I think I said novel, yeah. If they're familiar with that, then that's where ideally they would want to stay or function better. So the novel environment's the one that's new. So what happens when the family finds out somebody's like losing their vision, and how are they going to function at home? And now let's take them out and stick them somewhere that they've never been in an apartment and that they have no idea where anything is, right? That's a whole nother host of issues. And then a simple versus complex environment. I don't know about you guys, but my home office during quarantine kind of blew up, and I had papers and stacks and all this stuff everywhere. I would consider that a pretty complex environment. Like if you think about somebody's junk drawer in the kitchen, how hard is it to try and find something visually in there for somebody that has visual impairments? Thinking about contrast in the environment, you know, have you ever missed that last step going down the stairs because you couldn't tell visually that it was the end of the step or the flat, and you kind of like Hulk stomp at the end, right? There's just not enough contrast to determine those things. Looking at background patterns, so is the background moving, such as like people or cars moving in the background? That's going to be harder to visually discern versus a static environment. But background patterns can still impact that static environment. So, you know, they've got that really nice like 70s style floral couch, and then you put the TV remote on top of there, and it's really hard to find, right? So trying to reduce the background patterns, reduce the clutter to make it easier. So this low vision home safety assessment kit, that's the one that's listed on there. It's through UAB. It's very, very detailed. But if you're somebody that is going to do home assessments, or you're looking at home assessments for low vision, it goes through like every room of the house, and then it like has all these checklists. So like every single thing to consider for every single room. So that can be really helpful just as a resource to help you think about all the things that you wouldn't necessarily think of. Talking about lighting. So brightness, I would recommend getting a light meter. This one's really only about 20 bucks that I bought it for on Amazon. This can be really important for helping you show your outcomes in your interventions. So you would just hold this on the surface, and then it tells you right then and there how many lux there is for how bright things are. So that's nice to use if, you know, you're looking at where, you know, they normally have lighting in the house, and you would say, oh, I'm going to test it. And, you know, they might have 20 lux, which is like super, super low. And then you recommend task lighting, you light meter it again, right? And then you're able to say, now they have 1,000 lux of light. That's a huge improvement. Now they're able to do this. So that's a nice way to show some outcomes. For brightness, you can either move the light closer to the surface or get a stronger light. There's obviously a ton of different kinds of lights. Some are better for overhead, some get hot, some, you know, have more yellow light. I'm not going to go into the specifics of all of those because it's a ton of different things. But just know that there are standardized assessments that help people pick what the correct lighting is as well. And that's kind of based on their needs and availability costs. Light bulbs are expensive. You also want to look at the presence of glare. So whether it's coming straight in through the window, or if it's indirect, like if you have a really glossy countertop and there's light reflecting off of that countertop, you know, you might need to cover it with something if they're going to try and do a task there, if the glare is bothering them, or, you know, turning the TV a certain way or whatever it is that they're trying to work on. You also want to think about unevenness, so like shadows and difficulty moving between shadows and light. So if, you know, they have a walkway to get to their mailbox and there's like a tree that's overhanging and then the shadow's halfway over the sidewalk, what is that going to do to impact their balance and things like that? You also want to think about the evenness of light. So I've got like this task lamp here. It's probably hard to see. This one's nice. This is like a luxe one. So it goes, it has different colors all within the same task lamp. So this is kind of a nice one to bring. I don't know if you can tell how it's going from like kind of yellowish light to like super clear bright light. But that's one that I just pack up and bring with me to help show people like the variations in colors and light and how to position the task. So you want to, you know, right over the surface and ideally coming from behind them, but if it's going to block or cast a shadow, then you wouldn't. I put a link to the home environment light assessment. That's one that Monica Perlmutter, my mentor, actually developed. And it's a standardized assessment for how to determine, help determine the best lighting in a home environment. So talking about magnifiers, it's important to know that the strength is prescribed by the physician, and sometimes it'll be in X's and sometimes it'll be in diopters. Just know that 1X is approximately 4. And it's important for people to know that a magnifier isn't going to fix their underlying disease, right? So if they have blurred vision, a magnifier is just going to make something bigger, but it's still going to be blurry, right? So sometimes I think they think the magnifier is just going to like cure it, but you're still going to have the scotoma or the blurriness or whatever it is. And they're still going to need to wear their glasses when they use a magnifier, right? So like glasses fix the refractive errors that are in your lenses. A magnifier is not, it's just making something bigger. It's not correcting refractive errors. So they still need to wear their glasses. What I didn't know going into this was that there's focal distances. So there's actually set measurements for how far away a magnifier should be from the task that you're trying to use it for. So I'll show you two different kinds of magnifiers here. So this is a stand magnifier. This is one that just sets right on the surface and it predetermines the focal distance. So if this was my sheet of paper, I'm dragging it across the paper. I'm not going like this to try and look through it. That's the exact focal distance that should be for that magnifier. So this is helpful if somebody doesn't have the hand coordination, you know, if they have arthritis or something where they don't have to be holding constantly a magnifier, the stand one works well. I put in the formula for calculating the focal distance. So it's basically 100 divided by the diopter, tells you how many centimeters. So if somebody had a 20 diopter magnifier, they would need to hold it 5 centimeters from the task that they're doing. It doesn't matter your distance from the magnifier. The only thing that matters is the magnifier's distance from the task that you're trying to do. So that's kind of something key to keep in mind. And the stronger the power, the smaller the focal field of view. So like this is a 44 diopter magnifier. You see how itty bitty tiny that field of view is, right? It's itty bitty. So you're only gonna get like a couple letters or maybe a tiny word into that magnifier view. So the stronger the magnification they need, the smaller the window that they're gonna be able to view it through, right? So this is a 12 diopter compared to the 44. So there's different types, handheld, stands, head worn. The variations between them, it's going to depend on what task you're using it for. You know, like a handheld, you can put your hands underneath it to be able to actually do or function in tasks. A stand one, you can't fit anything under there. The way we recommend moving the magnifiers is on a sheet of paper. You take it down, you either drag the magnifier across or you move the content. Either way, one will stay still, the other one will move, and then you will retrace your line with the magnifier and go down to the next line. So it's going across, backtracking, and then going down. What you really want to teach them is care and maintenance, how to change the batteries. There's a ton of electronic magnification devices. I'm not even going to get into all those, but that's like the CCTVs and the iPads and all the you know, ways to magnify things. I put this in here for your reference. So like, especially in acute care, when you think about discharge recommendations and patient education handouts and precautions and all those sorts of things. These are the recommendations for low vision health literacy. So, you know, recommendations for font, spacing, that sort of thing. Briefly touching on psychosocial. So, you know, a lot of the literature shows that, you know, there's reactions to having low vision, whether it's fear, frustration, lack of confidence. Like if you don't see as well, you are going to tend to like start isolating yourself and doing less activities because you don't feel comfortable doing them. I had a gentleman who had pretty severe vision loss, and he would stay in his house and move from his recliner chair to the bathroom because he felt like if he went any farther than that, he was going to fall, and he never left the house. So I think, you know, it can have a really big impact psychosocially, and we want to treat that depression or fear like we would with any other client. And then you think about the family's reaction, right? So you know, a family is then coming in and wanting to do everything for them or taking over things or wanting them to move out of their home. So there's that whole other aspect of it. Talking about handwriting, a real effective intervention technique is the PBS technique, where you tell them to print use big block letters and space out their letters. So a lot of my older clients write really beautiful script, but then they can't read their own lists back to themselves. So I tell them, instead of using cursive, it's really hard for them, but use big print letters, block it out, and have pretty big space between their letters. And then have them write it, and their way to get them to convince them is write it out in cursive, have them write it out this way, mail it to themselves, and open it a week later and see which one they can read. So that can be a way to get buy-in. The 2020 pens, like the Bold Writer pens, are awesome. So they write like a Sharpie, except they don't bleed through any of the paper. So we just keep a stash of these, and I'll give them out to any low vision client. That's really helpful. The tactual templates are things like the check writer guides or signature guides or envelope addresses. The Missouri Society for the Blind will send you those if you request them. I find that they're actually pretty hard for people to use. They're not as helpful intuitively as you think they would be, but you know, they can be somewhat helpful. Sensory compensations, there's a ton of things. I'll show you the website at the end. I don't want to take a ton of time on it, but you know, like all the bump dots or like puffy paint things. You know, there's something that you put in your cup and it alerts when you tell you the cup's getting full, so you can pour something without overspilling it. There's just like a billion different things as far as devices that will do things for you auditorily or tactily. I threw in a list of some common low vision apps. Now the person has to be willing to like be into technology and use the apps. A lot of these are free, some of them are not. So I typically go through and download all the free ones and just have them on my phone and use my phone as demo to see if that would even be something that would work for them before I even recommend or like have them try and do it. But there's a lot of different things out there. I put in some things that are helpful to kind of have in your toolkit. So things that you should always kind of keep with you. You know, I have tons of different like colors of electrical tape. So like white, black, red, because if they have like a black microwave, I'm gonna cut out little pieces of the white tape to put over the buttons that they use most often to provide that contrast, and then just write one big letter on them. So there's all kinds of things that you can do as far as modifying. I put in a list of these different services. So the Mind's Eye is a radio station that's free for people that have low vision. It provides different like radio and entertainment. Newsline reads them whatever newspaper they want audioly. The Wolfner Library is through Jeff City for free. They can get audio tapes like the audio book player and tapes. St. Louis County Libraries have a lot of options, and they even have a homebound service where they will deliver to people that can't make it to the library out of their home. Aurora Ministries provides Bible readings and low vision Bibles, and then the St. Louis Society for the Blind has a ton of stuff. So I always refer my patients, even if they're seeing us for low vision, to St. Louis Society for the Blind. They have a ton of good resources. They have amazing things there, a lot of assistive technology. They have grant funding where they can provide people with CCTVs and things like that sometimes. And then obviously I'm gonna plug our services since Monica is our resident outpatient low vision OT who's certified. We do outpatient in the home or the clinic, so they can come into clinic, but what's nice is we do outpatient in the home under Part B or their private insurance, so we can go and actually do everything in their home and get it like modified and set up. So she's a great resource to have. And I'm not far behind her, hopefully. And then I put a list of St. Louis low vision support groups. There's some national ones, there's online ones, there's phone ones, there's social media ones. I just wanted to compile that because I think that's a big part of the mental health component of low vision. And then I threw up some additional resources as well. The one I want to point out is like the Mattingly Low Vision and the Maxi Aids. If you scroll through those websites, you're going to see a ton of different like low vision adaptations. So like the Maxi Aids, I mean, it has like every little gadget you could ever think of that they've come up with for somebody with low vision. I didn't leave you any time for questions because I had so much info to share, but you can email me questions and then we can like compile them and send out answers if you want to. Yeah. If anybody wants to stay on for questions, let me stop my screen sharing here.
Stephanie, Mary was wondering if you're going to be sharing your slides, which I was going to ask you about that as well, but forgot.
Yeah, I can send those to you right now.
Perfect. And that way I'll send them out with the CEU certificates. Does anyone have any questions for Stephanie?
Yeah, that was like a lot of information, but just wanted to kind of give you resources at least.
You did a great job, and I actually learned a couple of things new.
That's impressive if I could teach you something new.
No, not at all. I mean, I'm not a low vision specialist, but I have delved into it, and I actually did an in-service once. And Mary Warren and Monica Perlmutter are just fabulous. So
Yeah,
you couldn't be learning from two better people.
I'm very lucky.
Barstow, I don't know her, but
She's basically the new Mary at UAB.
well, because I've heard Mary Warren speak at least 3 times now, and she got her start in driver's ed kind of stuff. She used to do a lot of that, and then kind of branched out into the low vision. She's great. Thank you very much.
Yeah, thank you.
You did a great job. Appreciate it.
Thank you so much.
And I agree with the resource of using the state, blind services. I use that when I was in home health. I used them a lot in Kansas City just because in home health, you didn't even always have the time or even really, I didn't have the training to thoroughly address low vision, but I would refer them to the to the county senior services for low vision, and they would come in and do full assessments and provide them with resources. My grandmother used them at her independent living facility and ended up getting them to come in and do a presentation to the whole facility. And they got a bunch of referrals for that. So now she has, the device that tells you when the cup is full because she has macular degeneration. So, and when I talked to the county about it, they said they want those referrals because it's kind of a use it or lose it situation with their funding from the state. So they really want referrals from therapists and from doctors so that way they can go out and provide those services and they don't lose the funding from the state. So they're really beneficial resources, especially for those of us that either don't have the training in low vision, but want them to get access to those resources, or who want them to have a more thorough, in-depth access.
I do have a question. I have referred people to the Missouri Society for the Blind and Visually Impaired, but they always had to have an ophthalmologist reference when I would go online and try and put their name in and their information for them to make the contact. It seemed like they had to have an ophthalmologist already in place. Do you know if that's still true?
Well, they now took the referral thing off of their website. They put
okay.
Site, and you have to call now, but they have their own clinic with their own ophthalmologist there now. They're getting started.
Makes sense. Good. Thank you.
Yeah.
All righty. Well, thank you everybody for attending in August, or sorry, not August. Gosh, it's still June. Oh boy. In July, we have the Fall Safety CEU, which is going to be by Mary Falsetti, and that is at 7 o'clock. So it's the first Thursday of each month. We're going to be doing these CEUs, so save the date. So July's topic is going to be fall safety. And then we have Cindy Kempf coming back. If you saw her on the telehealth webinar, she will be doing the August 6th CEU, and that is going to be on Medicare Part B billing basics. So that's going to be a great one for anyone who needs a touch up or more knowledge on CPT codes and why we have modifiers and what was the therapy cap. Is there still one? So both presentations should be really great. We are actively looking for other presenters. We have a few others lined up, but if you or someone you know is interested in presenting, please send their information to me. I'll put my email in the chat box, and also you can find information on our upcoming CEUs on the MOTA website. So we just recently added a tab underneath MOTA's continuing education tab. So it'll say MOTA CEUs, And when you click on that, that'll show you the upcoming CEUs we have. It has the Zoom links, the quiz links, as well as the recorded webinars. So the recorded webinars will be available for 2 months after they were recorded. And then after that, we'll discontinue them just because I can't keep up with that many webinars and issuing certificates because I send them out all myself. So with that, we'll probably end the webinar unless anyone has any last minute questions. But thank you so much, Stephanie, for being willing to give us a CEU, and you're welcome back anytime.
Thank you. I appreciate you guys.
Alrighty, folks, take care.